it's really my great pleasure to welcome Dr. Mary De Silva. She's the Deputy Chief Scientific Advisor to the Department of Health and Social Care. She supports the Chief Scientific Advisor, Professor Lucy Chappell, in all aspects of her role across government, the devolved administrations, and ensuring the policies and decisions are informed by the best scientific evidence and long-term strategic thinking. This includes advancing cross-governmental science, technology priorities, and setting the research priorities for the Department of Health and Social Care, including their new areas of research interest. So, of course, absolutely fundamental to listen to those in terms of what we are going to be doing and what we're delivering in terms of research evidence across the school. Mary is also Deputy Director of the Science Research and Evidence Directorate in the DHSC, and she's Head of Science and Engineering Profession in DHSC, increasing the department's capacity to build and use scientific expertise and evidence in policy making and through staff development. So again, another great opportunity for us to be able to engage. Some of you may have met Mary in the past in her previous roles prior to joining DHSC in autumn of 2021. Mary was Head of Population Health at the Wellcome Trust. And before that was an academic at London School of Hygiene and Tropical Medicine, working in global health research. So I'm really delighted to welcome Mary to the stage, to the virtual stage. You're really welcome, Mary. Mary's going to give a presentation and then has kindly agreed to take a Q&A from the floor. So Mary, over to you.
Great, thank you so much. I think I'd have rather heard you sing and dance than that long list of all the things that I'm supposed to be responsible for at the department. But deep breath. Great. Well, I'm sorry I can't be there in person, but really great that the Power of Technology has allowed me to join for this part of the meeting. So I'm going to talk about our new areas of research interest, but with a particular focus on public health. As my background suggests, I am deeply passionate about public health and about population health. I'm a population health scientist myself. And so I'm really excited about the work that you do and the lots of opportunities we have for more population health research through our areas of research interest. So just to reiterate, you should all know and love the Best Research for Best Health, the next chapter, which really articulates NIHR's research priorities. And again, to reiterate that there are three very strong areas where public health and prevention research is critical. So I hopefully don't need to reiterate those. And then building on Best Research for Best Health, when I joined, we felt that there was a need to have more specific and a smaller number, I guess, of research priorities, which really tackled the research priorities that the Department of Health had. So kind of higher level policy priorities as opposed to research priorities. And that resulted in the birth of the areas of research interest. Areas of research interest is something that every government department should have. Department of Health hasn't really used them much because we've had an NIHR and its own, long list of research priorities for NIHR. But as I say, we think it's actually important, partly for ministerial visibility and partly for increasing our impact on DHSC policy, to have really clearly articulated areas of research interest, which are designed for the research community to respond to. And obviously we have the NIHR vehicle through which we can fund these priorities. So it's really a win-win. A lot of government departments have areas of research interest, but have no ability to actually fund them themselves. So we're very fortunate in that regard. So these are the areas of research interest which we have launched, and hopefully you've seen them on our website, 3 by 3. So 3 priorities, 3 cross-cutting themes. Excuse me while I've got 2 screens. I'm going to look at my slides on the other screen. I'm not ignoring you. The 3 are really not rocket science, and so hopefully should not be any surprise to anybody in the room. They were developed pretty quickly. When I joined, it took about 3 months. I basically went around the department and NHS England and spoke to a wide range of policymakers about the things that they were really struggling with. So I didn't ask what research do you want done. I asked what are the policy areas for which you need to solve problems, but which you don't know what to do? What problems do you need to solve that you don't know how to solve, basically? And then we married those against NIHR's existing priorities, because we obviously wanted the areas of research interest to reflect what we were already funding and caring about as NIHR. And we also tallied them against Secretary of State's priorities, which, I mean, I've been there 9 months and we've had 3 Secretaries of State. So that was an interesting, interesting thing to have to do. But they definitely are meant to be the longer term complex problems which the NHS, public health and social care are facing, rather than flash in the pan quick, priorities which might change with changing leadership. I'll talk briefly through each of them, but really on the cross-cutting, we wanted to be very clear that in all 3 areas of research interest, we had to consider health disparities, we had to consider economic growth in its broadest sense, including a highly skilled workforce and a more efficient NHS and a healthier workforce in the UK population. And we also wanted to nod to the difficulties of accelerating the adoption and scale of innovation across the health and care system. Not to say that we're going to solve any of those problems, but that we should remember in everything we do that they are problems that we need to solve and we mustn't forget about. So we also have some cross-cutting outcomes across all of the ARIs. And again, these are very much based on NIHR core principles of improved access to an experience of health services, improved physical and mental health, improved quality of health and life and ability to work, reduce morbidity or mortality, and reduce health disparities. So, these are very much patient and public-centred outcomes, but also a list of service outcomes which include increased efficiency, reduced burden and costs across all parts of the health and care system. I mean, none of that, again, is a surprise. It's just re-articulating the things that NIHR really cares about. And then the last thing we did was really to identify those methodologies which we feel are essential for delivering the ARIs, and particularly highlighting the methodologies and the academic disciplines which we think are underfunded and need to have more attention, both through capacity building, but also through encouraging these academic disciplines to apply to NIHR when perhaps we don't get as many applications as we would like from these disciplines. Top of the list is my personal favourite, systems thinking. All of the ARIs are complex, wicked problems. They need to be addressed with a systems lens, and we are reaching out to organisations like the Royal Academy of Engineering to get support with that, and we're particularly encouraging systems approaches in applications to us. Data science is pretty obvious, as is economics. Behavioural research is another area that we really care about and we don't get enough applications in. And implementation science, for those of you who know me from Wellcome, is I think I can call it a passion. I am constantly amazed by how much money we spend developing interventions and evaluating them, and how little time and effort we spend into understanding how to actually implement them in the real world within a complex system. And I tried at Wellcome, largely failed to get Wellcome to care about that kind of stuff. I feel like NIHR is a much more fertile ground, being such a translational and applied research organisation. And I know that there's a huge amount of effort, particularly in the ARCs, that goes into this. So I'm really excited to be able NIHR to really deliver on that. And then evidence synthesis, fairly obviously, there's a real issue with how we translate the huge amount of amazing research which is funded through NIHR into policy and practice changes. Systematic reviews is one of them that we need to pay a bit more attention to. So a little bit more about each of the areas of research interest. So the first one is very, very much public health core business. It is also very much aligned with the major condition strategy, which hopefully you've seen. I'll talk about a bit more in detail, but it's basically prevention, timely diagnosis and appropriate early intervention for people at increased risk of poor health for the major disorders which contribute to the most morbidity in the UK population, which is that list. We very much care about primary prevention and tackling the major determinants of all of these conditions, such as obesity, smoking, physical activity, poverty, inequality. and very much look forward to receiving applications on that topic. So the way that the ARIs are working is that we've got this kind of cyclical process where we first of all understand what we funded and identify gaps in that. We then use those gaps to identify the priority questions which policymakers most care about. We then fund new evidence and research synthesis to fund those gaps. And then we work with the policymakers who've helped design the research gaps and the policy questions to make sure that they are able to use that evidence in policy and practice. It sounds simple, in reality, it's incredibly complex. So in terms of what we've already funded, this is some very recent data to show just in the last 5 years, just in research programs for NIHR, so not infrastructure, which we find very difficult to calculate or to count. This is what we've spent on early action research, over £500 million in the last 5 years across the major disorders. And a really significant chunk of that has been in prevention, which is brilliant. So we do have a fantastic portfolio in this space, but it doesn't mean that we don't need to do a lot more, as all of you know. So from looking at what we've already funded and talking to policymakers, we've then identified the major research questions. These are, a kind of broad overview, and it follows the patient pathway from primary prevention, secondary prevention, identifying those most at need, intervening early with them, managing conditions, particularly multiple long-term conditions. All of this is going to be reflected in the major condition strategy, which we publish in January next year. And then we want to fund new research. So this is all the things highlighted are the areas where we think public health has a really strong role to play, and we hope that you've either applied for these funding opportunities or will. So these are the live programme activities and activities that we have ongoing. The schools are obviously involved in lots of these, the dementia research programme, for example. You're probably involved in the ARCs as well. I probably should have highlighted ARCs. And then in terms of future plans, we're developing plans working very closely with Brian Ferguson on new public health research funding programme calls around prevention. And also, as some of you have contributed to, there is a proposal to potentially give extra money to the schools, across the schools, to do ACT early research to directly meet this area of research interest. So I hope this shows we're really trying to put our money where our mouth is and fund the community to actually answer these research questions. And the last thing is, what are the policy opportunities for using this evidence that we're generating? So there's 3 big policy opportunities at the moment. I've talked about the major condition strategy. The call for evidence was launched yesterday. I strongly encourage you to respond to that call for evidence. If the School for Public Health could put in a combined submission, that would be absolutely brilliant. And obviously encourage all your friends and family to do the same. We'll also be looking systematically across what NIHR has funded to make sure that we are, really representing NIHR research in the policy making process. And we'll be funding rapid systematic reviews, for example, over the next 6 months or so to make sure that we are collating the evidence that already exists. There's also a Prevention and Health and Social Care committee, or rather the Committee for Health and Social Care is looking at prevention. That call for evidence has closed. I hope you contributed to that, and the inquiry is sitting at the moment. And then the last opportunity is that Professor John Deanfield has been appointed as the government champion for personalised prevention, and he's working particularly on cardiometabolic disease, on how we can use, kind of harness the power of big data to do personalised prevention for cardiometabolic disease, which I hope there'll be an opportunity to feed evidence into. I'll talk more briefly about the other 2 because I'm very conscious of time. I want to leave time for questions. The reduction of pressures on the NHS and social care is the first ARI that we really went after in terms of new funding opportunities because of the pressures of winter. But I want to highlight it's not just winter, it's also extreme weather events, including extreme heat, and also epidemics and pandemics. So it is quite broad, and it's really about how we make our health system more resilient and how we make individuals more resilient through primary prevention and targeted intervention in vulnerable groups, which is clearly the job of public health. So again, just to flag, we have funded a huge amount of work in this space, but a lot of it, unsurprisingly, happened during COVID. So while the prevention looks great, 156 million spent in prevention in the last 5 years, actually, if you take out all the stuff we spent on COVID vaccines, suddenly we're down to 44 million. So there is a lot more work that needs to be done in primary prevention to protect vulnerable people from extreme shocks. And so in terms of the priority questions and funding new evidence, this really has all happened through the compound pressures call, which I hope you've all seen and I hope you're all applying for. The research questions which we have asked for people to respond to are these 5. And again, number 2 is really the one where we really need the public health community to respond to. How do we best protect people's vulnerable people's health and reduce avoidable hospital admission? Basically, prevent them getting sick in the first place, and when they are sick, treat them more appropriately in the community, stop them getting too sick. And that is everything from having better designed homes, insulation, welfare payments, support at schools, free school meals, you know, you name it, all the way through to vaccines. But it really, really does include primary prevention and the social determinants of health. And the last one is shaping and supporting the health and social care workforce of the future. And I really want to flag that this absolutely includes the public health workforce and community-based health as well. We are in much earlier stages of thinking through how this happens, partly because the NHS workforce strategy hasn't been published yet. And we obviously that's our big policy opportunity. We want to make sure that we are working in concert with those policy teams. These are the major areas of research that we want to look at. This will be, further down the line, but you can apply for NHR funding at any point for any of the ARIs. You don't need to wait for a cross NHR call. Please apply at any point and just flag in your application that this is meeting one of the areas of research interest. And it really is about making the NHS, social care and public health fit for the future. In a kind of reformist way. It's not obviously paying people properly as part of it, but it's really how can we have creative solutions to supporting and structuring our staff to meet the demands of a less healthy older age, and equally at the other end, children who are fatter and sicker than they have been in the past. That's all I wanted to say. Open for questions.
Thank you, Mary.
Oh God, I'm huge on the screen. That's quite frightening.
Thank you very much, Mary. And for when people are asking questions, just to say that although Mary is writ large on our screen right now, she's actually over there on that camera. So if you want to look at Mary, she's over there. So that's where she is. So Mary, thank you very much for that comprehensive but very whistle-stop tour through an immense areas of research interest and also forthcoming strategies and so forth, but also highlighting opportunities. So my question, I liked what you'd said when you went the first 3 months going around to people to say, not what's your research question, but what's your problem and what do you need to solve it? And that was going to be my question to you in terms of what's the problem and what can the school do to solve that? But I think actually you've given many answers to that in what you've actually presented. And I guess we're probably going to be here for the next ever number of years to answer that. Obviously this morning we've talked about our research programs and what we're doing, and also the opportunities that we might have across the 3 schools and building on the work that we've done so far. So that's all really exciting. I guess I'm just going to open the floor. We've got just a few minutes for questions for Mary. So does anybody have anything they would like to ask Mary from anything that they have said, or any of the opportunities that has arisen? And I think Mary should just to point out, which I'm sure you know, that in the audience we're all here wearing our SPHR hats today, but we have people who work on FIRST, we've got ARC directors in the room, we've got people who are on Lead UK PRP, etc. So Any questions from the floor for Mary? I think looks like you've stunned them all into silence, Mary. Thank you. We've got a question. Thank you.
Hi, thank you. Is that on? Yeah.
Yeah.
So we've heard a lot today in our sessions about the importance of public involvement in research in the school. So I was interested to know a bit more about how public priorities have informed the priorities that you've been presenting today.
Absolutely. So we've got the wonderful James Lind Alliance, and we carefully scoured all of the prioritisation exercises that they've done to form our questions within each area of research interest. So obviously the three areas were set by the kind of big policy challenges which the NHS and social care faces. But within that, we were then able to articulate the particular areas where public had said that this was an important area. What we don't have is kind of steering boards for each area of research interest. And if we had that, we would absolutely make sure that we had public and patient representatives on that steering board. We're trying to be kind of business as usual and light touch with how we implement the ARIs. So, which means working through all of NHR's existing processes and mechanisms and funding processes. And as you know, public and patient participation is embedded as a golden thread throughout everything. So obviously on the funding panels, etc., and in the projects that we fund. So I guess we're getting the involvement through the actual projects that will be funded through the ARIs.
Thank you, Mary, and a great question. We have been talking about that a lot today. Any further questions for Mary from the floor? GJ, please. We've got a rapidly roving mic. Thanks, Katie.
Oh, thanks very much. So I'm GJ Melendez-Torres from the University of Exeter. One of the goals that you said was to improve health outcomes for the 20% most deprived. I think my question is, what do you think is the appetite for policy action that will actually address the deepest drivers of that, which is to say the deprivation itself?
This is when I wish I didn't work for the government. I'm yet to work out how to say these things in a politically correct way. There is huge appetite within OHID to do this work, and this work is continuing. There is huge appetite to fund this through the NHR. We regularly fund it. Please keep applying. We will fund that research.
I think that we've got another question to follow up, but I'll just say thank you for that answer. There was a few words, but a great deal said. So thank you. Okay. So I think I'm being given the red flag. Maybe that's an intervention, Mary. But I'm going to say thank you very much. I'm hoping that this is part of the beginning of a dialogue between yourself and your colleagues in DHSC and an ongoing of that, but with you particularly in your role and what the school and the research that we do can do to support that, but also to ensure that implementation of the findings, which you said is so important, that actually once we've got that, we're answering the right questions, but then also we can get that evidence into practice, or at least to inform practice. So thank you very much, Mary. Thanks for joining us this afternoon.
My pleasure. Bye.